Brilliant. Shout out again. Can everybody hear me? Do put your cameras on.
Yes.
We want to thank you. We want to see you as well. This is an interactive session. Shout out again to Sophie for actually making sure this happens. She's been doing it all in the background, which is the reason we've had such a good session so far. Look, I hope you've enjoyed it so far, and thanks for joining this session. This is really a chance to share your experience, perhaps also comment on what you've heard so far, identified shared successes and challenges so that we can actually pull them together, because what we'd like to do is to produce a kind of cookbook on what's worked, how it's worked, and also what hasn't worked. That's just as important. Just as earlier on I presented something that didn't work, finding out why it didn't work is actually just as important about making sure we record things that did work. So what I'd like to do to start with, you had I've just put into the chat the findings from the evaluation. Could I just ask for people's initial thoughts, both on those findings, but also if there's any quick comments people have to make on what they've heard this morning about important lessons and how it relates to what they're actually doing. This is your session. This isn't about me speaking at you. So please do get involved. So any first thoughts from people?
Hi, I'm happy to contribute. I think
Great.
it was really pertinent what was brought up about sometimes the challenges I find is constantly having to justify what we're doing and why we're doing it. And I thought it was a really interesting point about obviously how we pay for various roles, but how we're also measured against different targets. And it is certainly something I've come up against. It's like, we get amazing feedback from the patients, really good quality things when we're looking at the wider determinants of health, but that doesn't tick a quaff box. And it's that sort of thing really that causes hindrance and seems to be what I'm questioned about the most is, well, why is this resource going in there? And yet, how do we capture that better and how do we put pressure on a system to realise the value of those roles?
That's a really, how have you managed to deal with that?
By being stubborn.
I'll put that down as a finding. Stubbornness is appropriate
I
and
think I,
required.
I I I walk around with a pocket full of patient not literally feedback, but like anecdotes, where I can turn around to anybody who says about our project. So we're doing a lot on cardiovascular care and healthy hearts, as I call it. And I mean, I talk about things like I've learned a lot from working with my multidisciplinary team. It's changed me as an advanced nurse practitioner. So our health and wellbeing coaches said something very simple to me, that they start by asking the patient what matters to me, as in what matters to the patient, and then they pin any actions on that. And it's such a simple and easy concept, and it works. But the minute that I've opened up those dialogues to patients, and you find out what happens, you get buy-in from them, and they are more likely to think about lifestyle change, absolutely, and we'll give them support with that and finances, but then they will buy into taking a statin or the hypertensive medication on the back of it because it's pinned onto something of value for them. And it was such an easy concept and it works really well. So I've been able to walk around with this kind of like a metaphorical pocket full of anecdotal cases where if somebody does say, well, what's happening with that project, I can say, oh, it's great because we've got people. I'm at the stage now where I am seeing definitive results in terms of blood pressure control and lipid control, but I can also throw in, and it's amazing what we've picked up with mental health and housing and the patient's feedback. And I do pin it very much on what the patients are saying to us, because that's of value and engagement. So, but it isn't easy. You still get questioned about kind of like, well, how many clinics is it, and how many hypertensive reviews does that mean for our practice?
That's a brilliant. Thank you so much for that, because what we found within across the programs is it's part of that flexibility, because we've not said this is what you started with, follow your KPIs, get your tick box going. We've said, and in fact significant numbers of people, just as you've actually said, they've gone to their focus group, their focus population, and said, what's your issue? This is what we think your issues are. What do you think they are? And they're usually totally different. And within the CCP, we allowed that flexibility and not had to say you must justify what you said at the start and do your KPIs from the start. That is actually, you've also talked something there really about the sustainability as well. It is about, I love the idea about being stubborn with it, but it's also about making sure that it matters to patients and you're able to use your patient anecdotes, so you've got those to hand. Has anybody else had similar sort of experiences? What about the issue of actually having to justify what it is that you're doing? Have people had that experience?
Yeah, definitely in Northwest London, we that is definitely something that came through. You know, I think we were looking at diabetes, foot care, and sort of the inequalities in terms of exacerbation of complications of foot care within diabetes, and the sort of central commissioners obviously have very clear guidelines, very clear targets and pushes on them of what they wanted to see, and that wasn't necessarily what we were doing, but we could see from our discussions with the actual service users that we were doing something, you know, what they wanted really. We were helping to connect people up, and it's very difficult sometimes if you're in that position where the sort of central sort of senior management is wanting something very different to what you're trying to do.
Rhoda, you were nodding vigorously there. What was your experience?
Well, yes, we could relate to that. I think, well, where my role sits is obviously I am employed within the NHS Trust, but my role, 50% is actually around the community services. So sometimes there's a conflict around, you know, what's the aim or where is the direction of travel between the community services and the trust. And, you know, it's very clear the strategic ambitions, but I think it's the delivery and the implementation. And again, it boils down to probably the funding and the commission. That's why, you know, everybody needs to just find their own way of how to deliver that. But I think the other thing as well in relation to that is that it's not so much about justifying of sort of what we do, but justifying to say that this is the right way to do, you know. It's how we influence NHS Trust in a way to have that mindset to really focus on the you know, the ambitions in the care community. So yeah.
Thank you. Has anybody else had that experience of basically having to justify what they're doing, given a whole range of other different priorities?
I don't mind sharing. Yeah,
please do.
I feel really privileged to be part of this group because I'm part of something that hasn't even managed to get started yet, and I've not given up hope of trying to get involved in something. But yeah, it's really interesting hearing people speak, because I just call myself a pirate, to be honest. I just constantly think that I'm just under the radar, just a bit off piste, just trying to do things quietly with no attention really, because if anybody starts questioning me, then they'll want me to tick a box. So I'm at the very early stages of building relationships, breaking down barriers with the Roma community in the city where I live, and that's taken me 18 months of just showing up and being present and listening to understand. But what I learned from that was that I couldn't do this on my own. I think I knew that. And so what I've had to do is try and connect with other parts of the system, and somehow had to formulate what I've called as a coalition of the willing, or COW for short. And I've made some connections with like housing, healthy housing, DWP, but it's taken me over 2 years, and the ability came through the warm spaces, where I was just able to go somewhere where people were all just going to get warm and have a free meal, and they were already gathering there. So I just used to go to be present and listen to understand. But it's, yeah, and then I was invited to be part of one of these amazing projects that just hasn't taken off, but I feel really passionately about it. So I'm just going to keep going until, and I think it's something to do with confidence. It's something to do with feeling empowered and supported to do this work, because it's complex, it's messy. I feel vulnerable most of the time. But I don't think I could have done it any other way. I think I needed to get grounded in my values, and my key phrase is, I don't know what I'm doing, but I know why I'm doing it. So I just wanted to share that I really appreciate what I'm learning on these sessions. I can't contribute to anything because it's not started, but I'm really hopeful that it will.
Dawn, that's fantastic. Well done for what you're doing. And you demonstrated again how important it is to have tenacity. It's such an important part of this, isn't it? And I do love the idea that you're under the radar there, because if you stick your head above the parapet, someone's get you to tick a box. Brilliant, fine. We'll put that in the final report. Thank you for that one. That's brilliant. Thank you. Paul, over to you.
Yeah, it's a general comment, picking up exactly what you've just said, and what, coming back to Dawn, when you say nothing's gone, the very fact that you're continuing to try and achieve it, that's a feature of this program. I mean, I think the idea that the program comes up with a fixed answer that says this is the way to do it is very much the idea of the way NHS England works and why it won't work. It's much more about looking for, I use this phrase, liberating the professions, where each particular area will have a particular contextual setting. And in that contextual setting, working with the parties that are there, forming relationships, and then moving forward is unique to that area. It isn't the same as sitting in Whitehall and say, this is the way to do it. That it comes all the way back to the classic example of why NHS England continually fails. And the problem here, I think it was something that Rachel was saying about management. The issue here is it's not being managed, it's being administrated. The whole area is simply saying, have you done this? Have you done this? And have you done this? And the problem here is it's not unique to healthcare. If you look at the education sector and the way that even, say, primary and secondary care operates, it's exactly the same sort of thing. Primary care, let's call it primary education, gets a set of targets. They fill in the boxes, they do this, they go into the secondary care sector. No one questions what goes on. And more importantly, no one really uses the governance structures to be able to say, is this valid? I mean, I've looked now at some of the secondary education sectors, where, coming all the way back to Pete, what you were saying about health literacy earlier, it is absolutely frightening. You have got 15 to 16-year-olds that cannot string a sentence together. And then we say, oh, we must get them into the job market. It suddenly becomes someone else's problem. It's bonkers. Until we have an honest discussion about how public services work, we struggle. And I think that the benefit to me is really about this program. And what the program can do is raise a series of issues and support those in each of the sectors as much as possible. So, Dawn, keep going. Rachel, if you've got problems, let us know. Rhoda, wherever, yes, please, we'll go. And all we can do is to try and support you as a voice. But the system, until we change the fundamentals, and I think part of this is the tight grip that the Treasury have on everything. These return on investment calculations, I could go and get a fag packet and do a better one and submit it and say, there you are, it's done, sorted. Oh yeah, we'll invest in that. No one questions the validity of really what's going into it. As long as it ticks the boxes, thank you very much. And we need a groundswell to really start to change things. Anyway, enough of the rant.
Paul, thank you. And that actually demonstrates some of the passion that we have within CCCP for dealing with health inequalities and trying to cut through some of the nonsense that actually stops us from achieving it. People have mentioned there about working with others. Could I just sort of move on to teamwork? Dawn, you were talking there about starting, and after a couple of years, finding people that you didn't have to refer to before, but finding there were others involved. That was has been a feature of a lot of the sites. I'm unusual also in I was actually leading in my local area. We had a CCCP, so I was actually for a while the leader of that site. So I can talk as actually as a member of one of the sites. I mentioned earlier on about the North Koreans in particular, that they were hidden. It's all very well saying hard to reach. They didn't want to be reached. They were hiding, and we produced that 5 ways to well-being after the initial contact with them. And for the first time, as a result of the CCCP work, we got everybody together who was actually involved with the North Korean community. And there are a lot of people we'd never seen before. General Practice had no idea these people existed. They actually had no idea that General Practice was interested in it. And as a result of the first meeting, we were able to generate a vast amount of information about all these programs which were already there, and all these people. And in fact, so a significant part of it was actually, once those connections had been made, people could then work together. But consistently what people are saying is they start, particularly GPs and PCNs have said they've started and suddenly discovered all these other people in the actual field that they've been able to work with, that they're kind of not alone in that. Have other people had that sort of experience? What are around the issue of teamwork and working with other organizations and departments? Have people got any sort of had any experiences they'd like to share on that?
I don't mind, Pete, but you might
Rhoda.
hear some of it later on because I'll be presenting shortly. But in our area, we work very closely with primary care. So GPs are actually very involved with some of the projects in the community. And you know, we're quite lucky, and because their GP practices are merged, probably it's quite easier for them to sort of collaborate with community services. And one of the advantages are co-location, you see. So we and the formation of our care committee group and the core group in the care committee brings so much benefits. And also having a clinical lead in the care community, that is the one of the vital, I think, to make sure that the rest of the GPs are driven to you know, face externally rather than internally, and that there is a lot of assets in the care community that could actually help them. And I might touch that a bit later. Thank you.
Thank you so much. Before I bring Paul in, can I just ask, because the time is flying on, are there any specific challenges people would like to mention? And we've heard some of those already, which have been absolutely brilliant. But from perhaps people who haven't spoken so far, are there any specific challenges that you've actually come across? And what are the challenges you've experienced? And what do you think the challenges are going forward? Any other views on that? And that includes people who've already spoken. Your main challenges in this health inequalities work. No
I'll just
challenges.
put in governance. I think number one is governance, I think.
Yes. Any other experiences? Any other difficulties? Can I go to Rachel first, Paul?
So I would just say it's not a difficulty, but it's something I'm trying to navigate, which is building those relationships, I say, with external parties. So trying to work more with our local library, trying to get kind of faith groups involved, those sorts of things, and getting over all the logistics of different organisations and partnership working. And then you get into this wonderful territory of data protection and all of those things as well. So they're the things. I wouldn't say it's a problem. I'd say it's a challenge that I'm navigating, but it's new territory.
And you're stubborn, so you'll experience it.
Yeah.
You'll get it right, definitely. Data protection, that's an interesting one as well. Paul, over to you.
Yeah, it picked up. I don't know whether we've got anyone from ICB here. I mean, Sarah's listed as one, but one of the developments that I haven't seen occur in the sites that I've been helping support centres around the monies from Health Education England. Here is what I would call, we've got a situation where there's a training deficit. And actually, Health Education England have considerable sums of money to allocate, and an awful lot seems to go over to those that already get lots of training, namely the consultants and their more specialised pieces of equipment. One of the areas that I think does need to change is exactly this, and supporting primary care far more. And I want to give an example that I've been involved in where we're looking at oral cancer. Rhoda, you mentioned primary care. And I would say this, but don't forget dentists. I mean, one of the things that I always found interesting is that where you look at patients, where do they go for advice about oral cancer? It's doctors who get no training whatsoever in oral cancer. They go to pharmacy, no training whatsoever, and then they end up in A&E because they've been missed. And so what I'd argued with HEE is to bring primary care teams together and say, right, let's look at oral cancer. How can you each support this, and what can you do about it? First of all, to make sure that there was commonality in messaging, because if you're a patient, what is it that you want? And it was just amazing how little thought had been given to that. But I won't go in any more into that particular example, but it was literally primary care teams said, I didn't realize you're on the same street as I am. Two different practices. They weren't talking to each other. They've never seen each other, and yet we're so all there to do the same job. And I think part of this is mapping the assets which you've got in an area, which sort of say, if we're going to do this, let's bring that team together. And don't worry, it's not new money. Go to HEE, say, please, can we do this as a program? This is why we want to do it. And let's see what happens from that.
Can I just reiterate how important that is, Paul, and actually sort of discovering and mapping what's happening in the area, which I have to say with the Korean community was absolutely crucial. By the way, there's a South Korean community and a North Korean community, and without saying too much about it, they don't necessarily interact. So it was important to speak to the right people. My final sort of discovery that we had there, and the reason why to a certain extent it was almost over before it began, once we'd finally got the contact with the people that were really leading the North Korean community, we discovered they'd already made their own arrangements with the local mental health service that nobody knew about. And they'd already gone through that, and it was working so effectively that none of the vast numbers of people who actually had PTSD and various other things, none of them had to be referred into mainstream mental health because they dealt with it themselves. So that discovery was a very important part of the success of the whole program. Anne.
Thanks. I'm aware we're going to get whistled back into the main room in a second. I was just wondering if anybody had any stories or thoughts about sort of the limitations in terms of having places to signpost onto, resourcing, etc. I know we had something we kept stumbling across was with foot care. Often there are many people who couldn't actually reach their own feet, that needed sort of support and help, but there wasn't actually anyone available to do that. And I'm just wondering if anybody had anything like that, any other stories.
If nobody, I would say that we had a very similar thing. Again, sorry to mention about the Korean community again, but it was very much, as was mentioned earlier on in the health literacy thing, which I'll bring in again. There was absolutely no point putting anything, although we did that wonderful 5 ways to well-being, there are only a minimal number of people from that community that can actually read their own language, let alone English or any other language. And a lot of that then was actually solved by having social prescribers and link workers, which we talked about earlier, who were actually associated with that specific group. and it took a good while for the trust to be actually built. So the other aspect of this is around trust, so that people were actually felt able and safe to actually speak. And in the end, it was actually somebody from the community themselves that we actually set up to be the point of contact, and then things started to work after that. Any other are there any other reflections that people have that perhaps we haven't referred to, which you'd like to feedback either about what you've heard today, or particularly about in your sites, and if you're not in a site, the experience that you've had of having to work with other organizations, having to make something like this work despite all the pressures, or some elements of health literacy.
I don't mind sharing just briefly,
Dawn,
working
please.
with other organisations, because when I was just kind of showing up at the warm spaces for free coffee and biscuits, and listening to people and understanding that I work for a lifestyle service, people, to support people to lose weight and stop smoking. It was never at the top of the agenda of any of the people I ever spoke to. What they talked about was caring responsibilities, housing issues, benefits, rights to remain, and all sorts of things that were way out of my area of understanding. So that's where I sort of started with trying to make those connections so that I could have conversations in the future that made me feel more confident, because if I didn't want to give them a leaflet, a lot of them didn't read or write. They didn't even have a language that was the same for the Roma community. There's all bits and pieces cobbled together from what I've understood. So I then went on a bit of a journey of connecting with people in different parts of the system. And what I soon realised was these underserved, overlooked, seldom seen, seldom heard communities were on everybody else's radar, and they couldn't get in touch with them either. Yes. So suddenly, I've worked so hard to build up trust with this community, and I'm very protective of it. But now what I get is people getting in touch with me saying, I understand that you've got a connection with the Roma community and want me to be a door opener. But what I don't want is for people to come in, tick a box and disappear, promise things and not deliver them. So it's put me in a really awkward position, really, where I'm fiercely protective, but want to help them. So I've had a message while I've been on this call from somebody who sent me photos of his child's bedroom infested with cockroaches and mice, and he said, please, can you help me? So yeah, connecting with people, yeah, great, I need to do that. But then also I understand the constraints they're working within. They've only got a limited amount of time, resource, and they've got to show an outcome. So I kind of, for me, I definitely feel a bit stuck.
Oh, that's brilliant. And I'm glad you have the tenacity that you're able to deal with it. Just on the Roma community, we're probably going to get cut off soon. There's a related project that I've been involved with the Roma community. And because people were, I think we're about to go, people were complaining that the Roma community were not accessing general practice properly. And then, so when we actually met with them, they said, well, we can't read and write. Most of us, 75% of us can't read and write. So don't bother putting anything right. You don't say that we need to read text even. And in fact, what happened is they were actually communicating via WhatsApp video messages. So what we did is actually produce video messages for them. And suddenly, because we were actually talking to them in language they understood, suddenly they started to access general practice in what was considered to be appropriate, which they didn't know about before. And yet they were being criticized, they were being judged for not doing something properly, when effectively nobody had spoken to them before, or not spoken to them in a way they could understand. So the video messaging, I can put you in contact with somebody that's actually done some of that.
Thank
I think
you.
we're going to
That'd
go
be great. Thank you
so much for everybody. It's been a really rich conversation. Thank you. And we're just going back now, I think, within the next few seconds. Anna's had to go as well, unfortunately.